Hi everybody, welcome to Dr Manny's YouTube Learn Shops. This is Pharmacology for Nurses, Part 7, where we'll be reviewing neuromuscular blocking agents. The learning objectives for this Learn Shop are just to briefly review neuromuscular physiology, selected neuromuscular blocking agents, and then just see what you know at the end of the Learn Shop. Let's remember that the nervous system has two parts to it, central and peripheral. Remembering that the brain is the computer that controls the body. The spinal cord is essentially the main wire that connects the brain to the body. And then you've got peripheral nerves, small wires that connect the brain to various parts of the body. Now, the central nervous system consists of the brain and the spinal cord. And the brain plays a central role in the control of most bodily functions, including awareness, movement, sensations, thought, speech, and memory. The peripheral nervous system, that's the division of the nervous system containing all the nerves outside of the central nervous system, and the primary role of the peripheral nervous system is basically to connect the central nervous system to organs, limbs, and skin. Then we have the muscular system. And the muscular system is controlled by somatic or voluntary components of the nervous system and autonomic, involuntary components of the nervous system. The neuromuscular system then has a combination of the neurology and the muscular system. We have muscle fibers that are connected to a neurotransmission system, and they are connected so they can be activated. The muscle fibers are connected to motor neurons, which provide stimulation via action potentials or a current. Then you've got the neuromuscular junction, and this junction has to provide and maintain one-to-one transmission of electrical impulses to each of the muscle fibers. Acetylcholine, ACH, is the parasympathetic nervous system hormone. Receptors for ACH, acetylcholine, are the nicotinic and the muscarinic receptors. Now, with neuromuscular function, we need muscular activation. And if you follow the diagram, 1, acetylcholine is released by the neuron of the synaptic vesicles. ACH moves across the synaptic cleft and binds to muscle ACH receptors, and then the muscles work. When we want to deactivate, acetylcholine is released by the neuron synaptic vesicles. They move across the synaptic cleft, bind to the muscle ACH receptors, and then acetylcholinesterase, ACHE, breaks down ACH, acetylcholine, and the muscles stop working. They don't stop working essentially, they just stop contracting, not moving. So, after the muscle stimulation, ACH, acetylcholine, is rapidly broken down by the enzyme acetylcholinesterase, ACHE, as you can see in the diagram. So then what is the role of neuromuscular blockers? What do? Essentially, they stop communication between nerves and muscles, neuromuscular connections. And as a consequence of that, because they block the communication, this results in muscle paralysis. You have a neuromuscular blocker which fits into the site you can see in front of you. So therefore acetylcholine cannot go into its receptor at the nicotinic or muscarinic receptor at the neuromuscular junction. So therefore you can't get movement. Now, when it comes to these agents, we have competitive, non-depolarizing neuromuscular blockers, and these are competitive acetylcholine antagonists that bind directly to nicotinic receptors on the postsynaptic membrane, as you can see, blocking the binding of ACH so that the motor end plate cannot be depolarized. This leads to muscle paralysis. Then you've got depolarizing neuromuscular blockers, and they block by binding to but activating the ACH receptor. And when this happens, you get a muscle contraction, one only, followed by paralysis. They bind to the receptor and cause depolarization by opening sodium channels. Therefore, they act as an ACH receptor agonist where non-depolarizing muscle relaxants act as a competitive antagonist. Now, non-depolarizing acetylcholine blockers act to block ACH receptor sites in an overwhelming competitive manner, so no depolarization occurs. One example, one of the first neuromuscular blockers was Pancuronium Pavulon. It blocks neural transmission at the myoneural junction by competitively binding with acetylcholine, the cholinergic receptor site. This is used for general anesthesia, or for those of you in critical care, mechanical ventilated patients, if they're non-compliant, or just in an ICU setting. The major adverse effects are salivation, tachycardia, hypotension, and bronchospasm. The additional dose depends on your physician or your organisational policy, but the additional dose is typically 0.04 to 0.1 milligrams per kg, and then additional doses can follow at 0.01 micrograms per kg. Peak effect is typically in about 3 to 4 minutes and lasts for about 35 to about 45 minutes. Pancuronium Pavulon. Then you've got Acetylcholine, and this blocks neural transmission at the myojunction again by competitively binding with cholinergic receptor sites. Also used for general anesthesia or critical care settings. Loading dose is typically 0.4 to 0.5 milligrams per kg, followed by an infusion at 2 to 15 micrograms per kg. Remembering that this will vary with organisational policies and physician or intensivist preferences. You've got cis-acetylcholine, Nimbex. The action is basically the same, blocking neural transmission at the myoneural junction competitively. Uses again, indications, general anesthesia, critical care. Major adverse effects, bradycardia, hypertension, and bronchospasm. There is an antidote for non-depolarizing agents, an antagonist. Remembering that non-depolarizing agents, anticholinesterase, stop acetylcholine lysis. And the antidote is Neostigmine. Neostigmine stops acetylcholinesterase, ACHE, and lets ACH, acetylcholine, accumulate. And because it accumulates, it's not being broken down, the muscle reactivates because acetylcholine can now go to the receptors. Neostigmine then inhibits the breakdown of acetylcholine by acetylcholinesterase. ACH, acetylcholine, basically accumulates and binds with all the body ACH receptors, and this includes the heart. And if it includes the heart, this can cause bradycardia. In the adult dose and pediatric dose, you can see it in front of you, but in the adult dose and with the pediatric dose, we give prophylactic atropine. And atropine is given because of the potential for bradycardia to occur when you give neostigmine. The indications for the use of neostigmine is to reverse the neuromuscular blocking agent. And look, in some musculo-neuronal disorders such as myasthenia gravis, it can be effective. Major adverse effects include bradycardia, hypotension, seizures, and cardiac arrest. I think it's important that we do briefly discuss atropine sulfate. Atropine sulfate, well, you could really consider it a resuscitation medication, but we're giving it prophylactically about 1 minute prior to giving neostigmine as the antidote. And it blocks muscarinic and nicotinic receptors in relation to ACH, acetylcholine. And if it blocks, it increases heart rate and prevents bradycardia. Adult bradycardia is treated with 0.5 milligrams every 3 to 5 minutes to a maximum dose of 3 milligrams. And in pediatric bradycardia, 0.2 milligrams per kg, 3 to 5 minutely to a maximum dose of 1. And look, this can vary. If you look at your American Heart Association recommendations, it can vary depending on whether it's a neonate or pediatric, which is youngish or olderish, toddler versus child. You can look at your organisational policies. The indications, however, are prophylaxis prior to neostigmine and symptomatic bradycardia. Adverse effects include tachycardia, hypermobility of the bowel, and hot, dry skin. But we're really probably concerned more in this situation with tachycardia. Now, depolarizing neuromuscular blockers, they create an overwhelming, persistent stimulation to receptors. The membranes become unresponsive because they're exhausted. Muscle contraction cannot reoccur until they return to a resting state. They're in a constant state of depolarization. Now, the only one that I'm aware of is succinylcholine. Succinylcholine. And it acts similar to ACH, non-depolarizing motor end plate, producing sustained, flaccid muscle contraction and paralysis. Typically it's used for general anesthesia, but also in the intensive care, critical care area. Major adverse effects include bradycardia, hypotension, tachycardia, and cardiac dysrhythmias, premature ventricular complexes, possibly even VT, ventricular tachycardia, probably unlikely ventricular fibrillation, but it's possible. The dose in an adult, 1 to 1.5 milligrams per kg, maximum 150 milligrams. Pediatric dose, 1 to 2 milligrams per kg. And in both situations, onset is about 2 to 3 minutes, peak effect 30 to 60 seconds, and duration about 30 minutes. Succinylcholine. Now, for succinylcholine and depolarizing agents, there's no antidote. The only antidote is time and intrinsic plasma pseudocholinesterase, which basically is your own cholinesterase to break it down. So you can't give a maximum dose, you just have to wait until your body decides how and when it's going to break it down. So let's review. Name the 2 types of neuromuscular blocking mechanisms. These are non-depolarizing and depolarizing neuromuscular blocking mechanisms. Name 2 non-depolarizing neuromuscular blockers. 2 non-depolarizing neuromuscular blockers include Pancuronium Pavulon, Acetylcholine tracheum, Acetylcholine nimbex, and one we didn't mention, which you can review yourself, Vecuronium, because there are many others. Name one depolarizing neuromuscular blocker. Well, there's only one that I'm aware of, and that's succinylcholine, choline, and nectine. Name the antidote for a non-depolarizing neuromuscular blocker. The antidote is Neostigmine. Prostigmine is the trade name, or one of the trade names anyway. State the rationale for giving atropine prior to reversing a non-depolarizing neuromuscular blocker. The rationale is to prevent symptomatic bradycardia and hypotension due to large amounts of accumulating ACH. Well, thanks again. That's the end of this Learn Shop. If you found this of any benefit to you, please recommend it to your colleagues, as I always suggest, or you can subscribe. And please continue to the last part of Pharmacology for Nurses, which is part 8, which you can see on YouTube. If you've got any suggestions, please let me know. See you in part 8.